My name is Talk Blanken, and I will present to you our study on coronary flow assessments with accelerated 4D flow MRI. So the coronary arteries supply the heart muscle of blood, and they can only do so if no obstructions are present. But when there's a stenosis, not enough blood can reach the heart muscle. We then speak of obstructive coronary ischemia. Currently, people suspected of having this condition are mostly referred for catheter-based coronary artery angiography. This is a very invasive procedure, and not all patients need to be stented. So guidelines now recommend to first perform non-invasive testing to identify probable obstructive coronary ischemia before performing this invasive coronary angiography. MRI can potentially be used as a non-invasive screening modality as it offers coronary angiography for morphological assessment and myocardial perfusion and coronary flow measurements for functional assessments. We know that coronary flow assessment is feasible by MRI. It has been done using 2D flow MRI. But the main drawback of 2D flow MRI is that it requires prior knowledge of the desired measurement location to be able to plan the imaging slice correctly. Now that's where 4D flow MRI comes in. With 4D flow MRI, you can image a volume and select a specific slice afterwards, or even multiple slices. But coronary flow measurements with 4D flow MRI has never been reported. The main difficulty with it is that the small size of the coronary arteries necessitates a high spatial resolution, leading to long scan times, and this can lead to poorer image quality due to patient motion. Now the good news is that in our group a highly accelerated 4D flow MRI sequence was developed, which allows for a high spatial resolution at reasonable scan times. Therefore, the aim of this study was to investigate the feasibility and repeatability of highly accelerated, high spatial resolution 4D flow MRI for blood flow quantification in the left coronary artery of healthy subjects at rest. We scanned 15 subjects and first acquired a DIXON water image to plan the 4D flow MRI on. And the 4D flow MRI was obtained in a scan-rescan manner for repeatability testing. Now here are some of the settings. We scanned with an acceleration factor of 15, which allowed for high spatial resolution at a scan time of around 12 minutes. Here are some examples of DIXON water images where you see the LCA branching off from the aorta, here in a transversal view. And the 4D flow field of view was then planned as a slab covering the LCA. The LCA bifurcates into LAD and LCX. We only performed measurements in the LCA. Here is what such a 4D flow MRI acquisition then looks like. You see the LCA running here in a magnitude image with velocity signal in it in the phase image. I will now show how we performed the flow and velocity measurements. We first made a longitudinal cross-section of the LCA, resulting in a coronal view, and then placed 5 measurement planes perpendicular to the LCA, resulting in cross-sectional images in which we contoured the LCA and also placed reference contours in the pericardial fat next to it. Here is an example of streamlines that were reconstructed from the measurements. Now please note that we only measured during mid-diastole, since during systole the contractional motion of the heart corrupted the image quality such that we could not identify the LCA. But diastole is actually the period of interest, since the coronary flow is highest during diastole. Here is an overview of the results, averaged over the subjects. So we measured flow and velocity in the left coronary artery, and in the pericardial fat we don't measure much, as expected. Now let's look at the mean flow and velocity values in the LCA. If we compare it to what we would expect, then the measurements are a bit low. So we are not there yet, but looking at the peak diastolic velocities we measured, they actually come quite close to values reported in echocardiographic and 2D flow MRI studies. Now you may wonder how this maximal velocity was determined. I will show that for a single subject. So on the y-axis, the maximal velocity, or Vmax, And we determined Vmax for each of the 5 measurement contours and each time frame by selecting the voxel with the highest signal within the contour. We here see a scan and a rescan curve, and the error bars indicate the variation over the contours. Now, from these curves, we determined the peak diastolic Vmax and the time average diastolic Vmax. Then, looking at scan-rescan repeatability, some Blend-Altman plots with coefficients of variation below. What we are most interested in is the repeatability of the flow measurements, since what we eventually want to measure is the coronary flow reserve. That's this ratio. So we will then not only measure flow during rest, but also during maximal vasodilation. And this ratio has great prognostic value. In healthy people, it's around 4 to 5. In patients, it's around 2. Now, with this in mind, let's look at the graph again. Our results indicate that we are able to detect differences of at least 0.67 milliliters per second. Now, the differences we expect to see between maximal vasodilation and rest are way higher than this, so we will be able to pick up on them. What we can conclude from this study is that non-invasive quantification of diastolic LCA flow is feasible with the use of highly accelerated 40-flow MRI. We were only able to measure during mid-diastole, but this is sufficient for CFR measurements, and our results indicate that the repeatability is acceptable for this purpose. The spatial resolution is not good enough for measurement in the smaller LCA side branches and the right coronary artery yet, because of partial volume effects. And eventually, the flow should also be quantified during vasodilation, which might be more difficult due to a higher heart rate and more breathing motion. On the other hand, higher velocities and a larger luminal area might compensate for these difficulties. All in all, we took a first step towards non-invasive 40-flow MRI-based CFR assessment. We hope for our images to eventually look like this. This was obtained in an ex-vivo pig heart. With that, I'd like to thank you for your attention.